Well, hello, we're going to get started. I welcome you to our fourth session of Data Comes in All Sizes. And I just want to let you know, please put into the chat anytime you have a question, and we will be monitoring the chat. And at the end of the presentation, we will have a question and answer period. And please do feel like participating. We'll turn the phones on, and certainly would like you to ask your questions. So today we have Dorota Carpenetto. She joined Mountain Pacific in April of 2020 as a project manager on analytics team. She is responsible for supporting the interpretation, summarization, reporting, and presentation of data in a way that is clear, accurate, and meaningful to quality improvement efforts. Dorota has 14 years in public health practice, including 12 years working as an epidemiologist at the Montana Department of Public Health and Human Services. She also has 3 years of experience working abroad on public health and environmental issues. Dorota has a BS in International Business and Master's in Public Health from Tulane University. Her favorite part about data is bringing data to life or putting data into practice. I hope you enjoy this. We certainly like to hear from Dorota in our own organization. And without further ado, Dorota, it's your turn.
Thank you, Sarah, for the introduction. And thank you, everyone, for taking time from your busy schedules to join today's session. This talk might be the least exciting out of all my 3 sessions, but the content is very important to cover. During the next 30 minutes or so, I will briefly talk about data accountability, data sharing agreement, data use agreement, and business associates agreement. I will then transition to describe the data formats and how to make comprehensive data requests. Briefly, I will talk about the importance of data storage and data sharing, as well as the types of data. And lastly, I will provide a list of well-known data sources that you might be able to use. Next slide, please. To begin my presentation, I first would like to emphasize the importance of data for Mountain Pacific. Mountain Pacific adopted 4 ENDS policies, which describe the effect an organization seeks to have on the world outside itself. With that being said, one of the 4 ENDS policies we believe in is how people benefit from data-driven best health practices. At Mountain Pacific, we strive to make data-driven decisions. Anytime we utilize data in project implementations, we are applying all safety and security measures as agreed upon with the Centers for Medicare and Medicaid Services, known as CMS. Hopefully, you will see what I mean when I talk about data safety and safeguard measures in these presentations. Now, I would like to do the first polling question and find out if your organization defines end statement along with the mission. Mary, please pull up the first question. Now, I would like you to answer the first question. Does your organization define end statement along with the mission? End statements are about the purpose of an organization, why it exists, rather than what it does. So please select your choice. I think we can probably give 1 more second and we have our poll. Let's see. Okay, great. So seems to me that over half of the participants on this call are not sure if the organization has an end statement. And that is very true. I find that oftentimes we have to go back and remind ourselves what we believe in and how we utilize data. Next slide, please. All of us on this call heard about the Health Insurance Portability and Accountability Act, otherwise known as HIPAA, and most of us deal with it on a daily basis. I will only take a few minutes to give a high-level overview as a reminder of these important terms before I introduce data concepts. So HIPAA has been in existence for almost a quarter of a century. It was signed into law in 1996. It is a federal law that requires the entity to apply national standards to protect sensitive patient information from being disclosed without patient's consent or knowledge. Now, personally identifiable information, or PII, falls under HIPAA and includes any data that can be used to uniquely identify an individual. Remember that PII is not a term specific to HIPAA regulation. It is a broad definition of data that may or may not include health information. For example, name, phone number, social security number, email address, or personal URL web. Now, protected health information, or PHI, is a subset of PII. PHI is individuals' health information that is created or received by a health entity that may identify the individual. PHI can be in written, electronic, or oral form. PHI relates to past, present, or future physical or mental health status or condition, provision or payment for provisions of healthcare. For example, like PII, it can be a name, phone number, social security number, but it also has health information, such as diagnosis codes or medical record numbers. Next slide, please. When it comes to data sharing, specifically the release of very sensitive data that includes PII or PHI, it is critical that proper documentation is in place before any exchange of data occurs between entities and or individual. I will go over the commonly used agreements needed for data exchange. The Business Associates Agreement, or BAA, is a written agreement between the entity or individual holding the data and the entity or individual requesting the data with PHI and or PII. BAA usually documents the policies and procedures used to meet requirements for appropriate data safeguards to be established, ensuring the prevention of PHI disclosure outside of what is permitted in the signed contract. So to summarize, BAA is a standalone written document which specifies each party's responsibility regarding protected health information. BAA is required when exchanging or having access to PHI data. BAA must be signed when data set with PHI is being requested. So really, any time when dealing with PHI or PII data exchange or exposure, we're going to need BAA. Data Use Agreement, or DUA, is required under HIPAA privacy rule and must be signed before the disclosure of PHI and or PII data. This ensures that the person or the entity requesting the data adheres to the data privacy and security requirements and the data release policies as outlined by the entity holding the data. Now, to summarize, DUA is a contractual document used to transfer data. DUA is mostly used when dealing with limited data set. And I will go over the definition of limited data set in later slide. Most often, both DUA and BAA need to be signed when limited data set is requested. Example, Mountain Pacific has a BAA and DUA with CMS to gain access to Medicare claims data with PHI and PII. However, often DUA is needed when Mountain Pacific collects aggregate survey data without PHI or PII from coalition partners. Both BAA and DUA are common contractual relationships under HIPAA. The last one, Data Sharing Agreement, or DSA, which protects against data misuse and promotes early communication among entities regarding data handling and use. For example, DSA may be signed when there is no need to document the acceptable use of preliminary or provisional data by the partner or collaboration. So just to summarize, the DSA covers all data, not just PHI, so also PII. DSA really serves two main purposes. It protects the agency providing the data, ensuring the data are not misused, and it prevents miscommunication between the agency sharing the data and the entity or individual receiving the data. Next slide, please. Now I will switch gears and go over different data formats. So on this slide, you see an example of an aggregate level data. Aggregate level data contains non-identifiable data or data files that do not contain PHI and or PII. Aggregated level data could not be traced back to an individual. This type of data includes multiple individuals grouped into summary statistic from one or more sources, data elements, or groups of several years of data. To preserve confidentiality, data suppression for 10 or less events in a cell is often applied to aggregate data. On this slide, you see, like I mentioned, an example of aggregate level data. This map displays the number of active COVID cases in Montana by county on Monday, November 16, without identifying any specific person. Aggregated data can also be presented not only in map, but also tables, charts, or other formats, as long as it is aggregate. Next slide, please. The second type of data format is a patient-level data. Patient-level data contains identifiable data with PHI and or PII. This data can be traced back to an individual. Data may include names and detailed personal and service information. Example, data sets or data files containing single-level records such as age, diagnosis, city, date of birth, gender, or any other identifiable information about the individual. Patient-level data requires a data use agreement and or a business associates agreement, like we talked about, between the data requester and the entity releasing the data. This slide shows an example of patient-level data. As a note, these data are made up. You can see that the PII and PHI is released, such as names, steps per day, and weight status. Even though weight status is coded as 0 and 1, it is still PHI because it's related to individual's name in this table. Next slide, please. Now I'll talk about the limited data set. The limited data set, or LDS, contains personal level health information, but excludes 16 direct identifiers as outlined in the HIPAA privacy rule. These 16 direct identifiers are listed on the right side in my slide. I will not read them, but I'll just mention a few of them, like the phone number or web locator or an API address. It is important to know that the limited data set are considered identifiable data even without these 6 identifiers, because LDS data may include information such as dates of admission or discharge a date of birth, which, as you see, date of birth is not part of the 16 direct identifiers. Also, any data with individual or aggregated data, which I just talked about, such as age diagnosis with 10 or less cases in a cell, is considered limited data set. Remember that all of these 16 identifiers must be removed before releasing limited data set to person requesting these data. On the left-hand side of this slide, I included an example of CMS claims limited data set. These files contain fee-for-service claims submitted by institutional outpatient providers. Examples of institutional outpatient providers include hospital outpatient departments, rural health clinics, dialysis facilities, comprehensive outpatient rehabilitation facilities, and community mental health centers. CMS makes these limited dataset files available for researchers as allowed by the federal law and regulations in CMS policy. These LDS files contain beneficiary level health information and are considered identifiable files, but they do not contain the 16 specific direct identifiers as defined by the HIPAA privacy rule. All of CMS limited dataset files require to sign data use agreement between CMS and the data requester. This specific example I'm providing on the slide can be purchased from CMS for $3,000. Next slide, please. Now, at this point in my presentation, I will transition to more practical content, if you may, that may be utilized at some point. You might have to utilize at some point in your job. In my experience as an epidemiologist and data analyst, oftentimes I get data requests that are incomplete and consume a lot of time for both parties to figure out what is actually being asked for. That precious time can be saved if a comprehensive data request is submitted the first time around. This slide includes the information that is important to provide when requesting data. So we start, of course, by providing your contact information, such as name, phone, number, and email, the date needed by. So when is the latest date you need this information by? Include the purpose for your data request. Why do you need the data? Is it for a grant? Is it for a paper? Is it for a presentation? Is this request related to a past request, or do you have a table or a chart you'd like to have updated? If you do you have copies of those tables or charts that you can share so that we can help reduce duplicate efforts in case the latest data was already provided to you? Make sure you have the data need description. Are you asking for cause of death or diabetes rates? If you know, please include any specific data sources you're looking for. Does the data come from the Medicare claims, or is it from a survey collected last year? Be specific as possible. Limit the data request to a specific time frame. So provide years of data you want to include. For example, the most recent years of data. If you don't know the year of data that's most recent, you could just say the most recent 3 years, or you could say 2019 or 2019 going back to 2010. Do you need the data in geographic unit? Is it by state, county, region, or specific community? What are the demographics that you're looking for? For example, age groups, 65 years and older, race, gender, anything that would help to limit the data querying. Is this supposed to be an aggregate level or patient level data? Remember, we just talked about that. Describe if you're looking for summary or data files that you or someone else at your entity may be analyzing. Lastly, what is the preferred data format you like? Is it Excel table, map chart, PowerPoint, however you defined your need? Next slide, please. Of course, it is important to mention how data are stored and shared with someone outside the entity. Today, data are collected at almost every event on most electronic devices like laptops, phones, tablets, which means more than ever, we need to be mindful of protecting data against unlawful, unintentional, or unauthorized access, disclosure, or theft. Remember, data should be stored on a secure server and locked file cabinet or stored on an encrypted device and should be password protected. Data should be shared via secure and approved method, either file transfer protocol known as FTP or other secure encrypted transfer method established by the entity providing and storing the data. It is always a good practice to check with your IT personnel how the data you are collecting are stored. Or if you request data and are anticipating it soon, make sure you have a secure place to store that data when you receive it. You might be held accountable if their data breach occurs and that data somehow gets breached. Next slide, please. Now I'll briefly mention, thank you. Now I'll briefly mention the two types of data that I'm sure you all have dealt with at some point. Those are the quantitative and qualitative types of data. So what are the differences between quantitative and qualitative data? Well, quantitative data are numbers and use mathematical calculations to be summarized. Those type of data usually come from some sort of database, chart review, manual tracking sheet, surveys, etc. Whereas qualitative data are descriptive in nature and cannot be computed. For example, these data can be written stories, free text responses in a survey, or opinions gathered during focus groups. Now, we can think of outcomes for quantitative data that helps us to develop initial understanding of concepts based on numeric findings. For example, based on the number of new COVID cases, infections, we can start getting an idea what is the level of risk for increased prevalence of this disease. Whereas outcomes for qualitative data usually recommend a course of action. Let's say a set of written proposed rules or a list of steps, as we can use this as an example. Next slide, please. Finally, I'll go over the different data sources that are widely used and represent our population health, population count, mortality and morbidity on county, state, and national levels. These data sources may be different from what you used at your health center, nursing home, or whichever place you work at. But these data sources are widely recognizable and adopted as well as validated. They are often accessed by researchers at the CDC, state health departments, and academic institutions. These data can be complementary to the data you are using to describe the health of the population you serve. On this slide, I have included the most often cited data sources, and I broke them down by surveys. So as an example, one of the more usually recognizable survey data sources are the Behavioral Risk Factor Surveillance System, or BRFSS, or BRFS, like some say. These data provide us with an annual direct estimate for targeted group of people, in this case, adults aged 18 years and older. This annual phone survey collects data on health-related risk behaviors, chronic health conditions, and preventative services. These data are often seen by the CDC in conjunction with each health state department. You can find free data query system on the CDC website in most state health departments. Next, we have the population estimates. The American Community Survey, or ACS, is also an annual survey, but it provides us with an annual population estimate. Now, these estimates include only a single year of data by county and state, but they do not contain economic information, just demographic information. The decennial census which is an actual count of the population and housing. As you know, it was done this year and it's still ongoing. It's 99.2% complete. Provide more details and are more accurate count of the population. Decennial census are considered the gold standard to represent our population count and distribution. These data are housed by the US Census Bureau. Now, the vital statistics or vital records include the state birth and death records. Birth and death records include and are collected at every state level and are aggregated at the national level for the whole US. These data include elements that are put down on the death and birth certificates. Vital records are managed on a state level and a national level by the National Center for Health Statistics Division at the CDC. In some states like Montana, for a small fee, a copy of the certificate may be released to anyone requesting it. Medical claims records such as claims data, hospital discharge data, emergency department visits. These are data that provide patient and provider office visits, hospital admissions, ED visits, medical history, lab results, patient outcomes, payment coverage, provider information, prescription fills, etc. These type of data are mostly aggregated in each state, either by the hospital association, or it could be aggregated by the state's health information exchange known as the HIE or some other method. And lastly, program-specific registries. This type of data sources may include aggregate or individual level data. For example, the National Program of Cancer Registry or the National Diabetes Prevention Program. Each of these are collected by the state entity like the health department, or they can be somewhat connected to the health department. The data are made available by the CDC and could be also available by the State Department. These program registry level data usually collect information specific to intervention or treatment, simple demographics, enrollment, outcomes, and some other information are gathered. Now we're going to do a second polling question to see what sort of data sources you are using or are most familiar with. This is a multiple choice question. And I believe if you have an answer that says other, you can put that in the chat.
Please make sure to, if any that apply, go ahead and you can do multiple choices too if you've pulled data out of any of these data sources. And Dorota, while they're doing that, I had a question. You said vital records, anybody can ask for a death record. Is that true without some kind of document or anything?
That's a very good question. So it's state by state. In Montana, it's considered a public record. So you just go in to the Vital Statistics Office and fill out a document and pay a small fee. And yes, you can request that. I think Arizona is another state that can release that information to the public.
All right, thank you.
You're welcome. Okay. Looks like we probably are done with the poll, and looks like everybody, well, 5 out of 5. So maybe not everyone answered the poll question, but a lot of people are using surveys and medical claims records. So I'm guessing data from an EHR, and some are familiar with the vital statistics. So that's great to know. Hopefully the information I provided today about data sources is not totally foreign or something new that you can take back and learn more about. So thank you. Okay, next slide, please. Yep, so right, this concludes my presentation. For some reason, I thought I had one more slide, but no, that's correct. Yep, this concludes my presentation, and I'd like to thank you for dialing into today's session and invite you to join session 5 on December 2nd, which will focus on basic statistical concepts such as proportion rates, how to interpret 95 confidence intervals. I'll give you some tips on how to interpret data and present the findings in correct and interesting ways. We will go over methods of data dissemination. And lastly, you will be given a short and simple assignment for our last session on December 9th. On December 9th, we will break into small groups to work on that assignment and then report back to the group. After that, I will provide few data display templates in Excel and PowerPoint that you can take back and hopefully you can use at your workplace if you choose to. And I'll also share a list of other data sources that may complement the work you do. And that's all I have for today, and we can open up the floor for questions. Feel free to put the questions in the chat box, and I think Mary or Sarah can unmute you to just have a conversation if you like.
Yeah, and please make sure to fill out the evaluation that has been put in the chat box. And as Dorota said, please ask through the phone, put any chat. If there's any questions, please feel free to do so. All right.
It's tough to talk about data on Wednesday afternoon, but hopefully people will come back in a couple of weeks where we can have some interactive discussions and look at some data in detail. So, yeah.
All right. Well, thank you for joining, and please do attend the next couple sessions and hopefully be very interactive, and you will have some practical homework to do too. Thank you very much.
Thank you.